So first of all, clearly, I would like to thank for the invitation. It's a pleasure to be here. And so these are my disclosure. I did selected some of the trials that were published in 2024 or on coronary space. The first that is going to change our practice was the danger shock trial. It was published in 2024. This is on Impella CP on specifically cardiogenic shock as a complication of acute myocardial infarction. They did randomize 355 patients to standard of care hemicryoaxial flow pump, and the endpoint at 1 year was death from any cause at 180 days. And then there was the composite safety endpoint that took into care severe bleeding, lumbar ischemia, hemolysis, device failure, or worsening of aortic regurgitation. And these are the results. The study was positive, and this is the first trial that we have positive in the setting of cardiogenic shock with the MCS. And there was a 12.7% absolute reduction in 180-day mortality in patients who did receive Impella as compared with standard of care. However, there were a higher rate of complication in Impella CP group as compared with standard care group, despite the fact in a later sub-analysis of the trial, these bleeding complication did not impact in mortality. Second study actually is a meta-analysis, an individual patient data meta-analysis of all randomized trials taking into account MCS in the same setting, so infarct-related cardiogenic shock. And 9 randomized clinical trials, 4 with via ECMO, 5 different left ventricular unloading devices. The usage of MCS in general, so they took into account also intra-aortic balloon pump and ECMO, did not reduce six-month mortality, but however, a major determinant that came up from this analysis was the issues of hypoxic brain injury. Because indeed, in the patient who did not experience hypoxic brain injury, the mortality was reduced with MCS. So it makes a clear statement regarding phenotypization of cardiogenic shock and to make a difference if the patient is in cardiac arrest and the cardiac arrest led to hypoxic brain injury. So this was the determinant. With, there was no difference in mortality, it's too late. Without, indeed, there was a decrease in mortality. Let's go indeed in trials on imaging. First trial is intravascular ultrasound-guided versus angiography-guided PCI in acute coronary syndrome. Does IVUS guidance compared to angio improve outcomes of PCI during acute coronary syndrome? 3,505 patients were randomized. Primary endpoint was a target vessel failure as a composite of cardiac death, target vessel MI, or clinically driven target vascular revascularization at 1 year. And these are the results. The study was positive for the study hypothesis, and there was indeed a lower occurrence of the primary endpoint, target vessel failure, if the IVUS was used, 4% versus 7.3%. And no difference in death and stent thrombosis. So also this trial just showed the importance of IVUS and imaging guidance in the setting also not only of CCS as we know, but in acute coronary syndrome. Other trial again with imaging, in this case indeed we go back with the CCS and complex lesion, OCCUPY. Can OCT guidance reduce MACE as compared to angiography-guided PCI in patients with complex coronary lesion at 1 year? 1,604 patients that were randomized to OCT-guided versus angiographic-guided PCI. Primary endpoint was MACE at 1 year. And the trial was a positive trial because there was a reduction of the primary endpoint in the patient who were randomized to OCT-guided PCI, 5% versus the one indeed randomized to angiography-guided PCI, 7%. No difference in stroke bleeding events and contrast-induced nephropathy. So OCT guidance for disimplantation in complex lesion led to a smaller risk of 1 year composite endpoint. Regarding indeed the physiology, actually this trial was published after the guidelines were from European Society of Cardiology were out, and indeed the guidelines did recommend with a class 1B recommendation the usage of QFR. After that, there was published the Favor 3, and the question was, does a QFR-based diagnostic strategy provide non-inferior 12-month clinical outcome as compared with FFR? 2,000 patients were randomized. Primary endpoint, again, is a composite, cardiac death, MI, unplanned revascularization 1 year. And the trial was a negative trial because QFR did not meet the non-inferiority to FFR. And there was the margin at least that was calculated, 6.7% in QFR as compared with 4.2. So the study is a negative trial. It will for sure impact on the next guidelines. Again, FFR coming back, and the issue of full revascularization in the context of complete or culprit-only PCI in the context of myocardial infarction. Does FFR-guided complete revascularization improve outcomes in STEMI or high-risk non-ST elevation with multivessel? 1,542 patients were randomized to FFR-guided revascularization versus culprit lesion-only PCI. Primary endpoint, cardiac death, MI, unplanned revascularization in 1 year. And the trial was a negative trial because there was no difference. And actually, the primary endpoint occurred in 19% and in the complete as compared with 20.4%. So this trial went in opposite direction as compared with other trial, but however, the patient population was different. So FFR-guided complete revascularization was not shown to result in a lower risk of composite of death from any cause, MI, or unplanned revascularization than the culprit lesion-only PCI at 4.8 years. Another trial, indeed, in the prevention of vulnerable atherosclerosis coronary plaque. So this is the PREVENT trial. Does preventive PCI of non-flow limiting vulnerable plaque improve clinical outcomes compared with optimal medical therapy? 1,600 patients with non-flow limiting vulnerable plaque with FFR more than 0.8 were randomly assigned to PCI or OMT. Primary endpoint, again, is a composite of death from cardiac cause, target vessel myocardial infarction, ischemia-driven TVR, or hospitalization for unstable angina, up to 2 years. And indeed, there was the hypothesis of the study was demonstrated, and there was a reduction in the primary endpoint if indeed the PCI was performed, 0.4% versus 3.4%, with a quite long follow-up up to 5 years, and the advantage was confirmed. Other trial, indeed, in the setting of refractory angina, it becomes to the family of the ORBITA trial. So it's called ORBITA Cosmic. So coronary sinus reducer effective on myocardial ischemia reduction and symptom improvement compared to placebo? As always, from this series of trials, the population is quite limited. There were a total of almost 50 patients, only 50 patients randomized. And there was done adenosis stress MRI, and were taken the questionnaire of quality of life. It was a blinded procedure with a 6-month follow-up with daily QOL questionnaire on an ORBITA app plus MRI, and the primary endpoint was MBF in segment design ischemic at the enrollment during the adenosis stress MRI and symptoms. And these are the results. MBF in ischemic segment did not improve with the usage of coronary sinus reducer, but however, there was a reduction in the daily angina episode in the group that was treated with coronary sinus reducer. Another trial on drug-coating balloon angioplasty, REC-CAGE-3-1. And this is drug-coating balloon angioplasty with rescue stenting versus intended stenting for the treatment of de novo coronary artery lesion, multicenter non-inferiority trial. Is DCB angioplasty with rescue stenting non-inferior to intended DES deployment for de novo non-complex coronary artery lesion? 2,272 patients were randomized. Primary endpoint is device-oriented composite endpoint, dose, including cardiac death, target vessel MI, target lesion vascularization 12 months. And indeed, there was a 6.4% of occurrence of the primary endpoint in DCB group as compared with 3.4% in DES group. And DCB angioplasty with rescue stenting, because of the trial design, did not achieve non-inferiority. So this is a negative trial compared with intended DS implantation in terms of dose at 2 years. And this is why the author conclude that DS should remain the preferred treatment in de novo non-complex lesion. ART STEMI, complete versus complete only revascularization in older STEMI patient. Is complete revascularization more effective and safer than a culprit-only strategy in older patient? 1,773 patients were studied from 7 randomized clinical trials, so this is mostly a meta-analysis. Primary endpoint, death, MI, or ischemia-driven revascularization. A complete revascularization reduced the primary endpoint up to 4 years, but not at the longest available follow-up. Complete revascularization significantly reduced the occurrence of cardiovascular death or MI at the longest follow-up. Eclipse indeed was a trial on technology, large-scale randomized trial of orbital atherectomy versus conventional balloon angioplasty in severely calcified coronary arteries prior to DES implantation. And the question is, if orbital atherectomy prior to DES implantation provide greater benefits to conventional PCI for severely calcified lesion. 2,005 patients were randomized. Primary endpoint was indeed what is called the surrogate endpoint, because it was post-PCI instant MCA at OCT, and then we did also clinical outcome endpoint, which is 1 year TVF, and primary imaging outcome, the instant MSA, was 7.67 in the orbital atherectomy versus 7.42. Regarding also the primary clinical outcome, there was no difference. So orbital atherectomy prior to DES implantation compared to conventional PCI without atherectomy failed to reach the primary and failed to reach the primary OCT endpoint as well as the clinical endpoint. Negative trial. Senorita indeed targeting the older women population is a conservative strategy of medical therapy or adding invasive treatment more beneficial for older adults with non-ST elevation MI. 1,500 patients enrolled, primary endpoint composite of cardiac death or non-fatal MI, and the invasive strategy did not show to be indeed different from a conservative strategy group in this older women population. So in older adults with non-ST elevation MI, an invasive strategy did not result in significant lower risk of cardiovascular death or non-fatal MI than a conservative strategy. And then the missed setting. So it's what about PCI in patients with severe aortic stenosis undergoing TAVI? 455 patients enrolled. Primary endpoint is MACE. And indeed, the primary endpoint occurred in 26 of the patients in the PCI group as compared with 36 in the conservative group. And we move, is it a topic of coronary or structural? We are in between most probably, but this is regarding mechanical thrombectomy in the setting of intermediate risk pulmonary embolism. This is the peerless randomized controlled trial. 550 intermediate risk PA patients with right ventricular dilatation and additional clinical risk factor were randomized to what is standard of care and indeed mechanical thrombectomy done, that was comparison with mechanical thrombectomy versus catheter-directed thrombolysis. And in this case, there was hierarchical win ratio composite, all-cause mortality, intracarinal hemorrhage, major bleeding, clinical deterioration, and post-procedure ICU admission. And the first endpoint occurred significantly less frequently when it was used a large bore mechanical thrombectomy as compared indeed with catheter-directed thrombolysis. So the peerless met its primary endpoint in favor of large bone mechanical thrombectomy versus catheter-directed thrombolysis in the treatment of intermediate risk pulmonary embolism. And the last is the guidelines that came out in 2024 from European Society of Cardiology. Just some sum up, what did the guidelines said differently? Gave a class 1B recommendation for patients with refractory angina and highly likely to have INOCA or ANOCA to do invasive functional testing. Gave a class 1A recommendation to intracoronary imaging guidance by IVUS or OCT when performing PCI on anatomically complex lesion, in particular left main, true bifurcation, and long lesion. And in the setting of the left main, kept the recommendation of 1A for PCI and CABG and take out completely the class 3 recommendation. Clearly, it is a class 1A recommendation, CABG, if there is left main and complex multivessel disease, but however, in patients that are turned off from the surgeon, so at high risk for surgery, PCI may be done. And that's very important because most of us in our clinical practice are referred patient refused by the surgery. And indeed, we did have priorly a class 3 recommendation. And for this reason, indeed, the task force gave a 2 class of recommendation. And most importantly, there was given lots of importance to the art team and patient center mostly than disease center. We discussed this before. So in our decision making is very important, not only anatomical characteristics of the lesion, but the patient comorbidities, the risk of the patient, the hospital practice that was taken into account, as well as one of the factors that we should evaluate is patient expectation and patient preference. So the importance of a valuable discussion with our patient, mostly taken by someone who is more neutral than the interventional cardiology of cardiac surgeon, the cardiology in charge of the patient, to have the best decision for that patient. And this is my last slide. Clearly, there is a QR code, and the one of you want to be part of the APCI family, simply register through that QR code. Thanks for your attention.